All right, everybody. Today's really just an overview of everything, and I just want to give you a sort of a sense of the landscape of transplant because many of you don't, get a glimpse into what's going on with transplant. And I think our program is very oncology, endourology focused a lot of times, and those are amazing fields with amazing people. But I'm here to show you that transplantation is pretty cool too. All right. Without further ado, I'll get going and I'll try and wrap it up in a reasonable time so we can all get a coffee before our day. So, monitoring the health of renal allografts following transplantation in the era of genomics. All right, I don't have any disclosures, no industry sponsorship yet, but I'm willing. So, why should you care about transplant? Just going to give you a few slides just on a background. In North America, there you can see our bars. We perform sort of the most transplants per capita in the entire world. So between the United States and Canada, not so much Mexico, we are heavy users of transplantation, and that's for good reason. There are 4 million Canadians living with kidney disease, and over 40,000 of these have end-stage renal disease. It needs to be known that there's no cure for end-stage renal disease. There's only renal replacement therapies because each therapy requires ongoing maintenance and checks. Over half of the people with end-stage renal disease are on dialysis, and most of these are on hemodialysis, and hemodialysis is one of the most expensive treatments in all of medicine. 42% of those patients with end-stage renal disease have a functioning kidney transplant here in Canada. And the obvious problem is the demand for organs far outweighs the supply. So anything we can do to improve the lifespan of kidneys that go in, or anything we can do to increase the donor pool, are always important concepts in kidney transplantation. So the advantages of transplant are cost, quality of life, and life years gained. Cost is, this is the one surgery in all of medicine that saves the healthcare system hundreds and hundreds of thousands of dollars, if not millions of dollars, over a patient's lifetime. And it's just because the cost of dialysis is so expensive compared to that of ongoing maintenance costs of transplantation. Whoops. Sorry, guys. So quality of life, patients who get a transplant just feel better all around. They have more freedom, they can travel, they just need some pills to go with them. Women who are of childbirthing age can have successful pregnancies, where with renal failure, sometimes hormonal disturbances create problems there. And in the pediatric realm, kids can have normal growth and development, where renal failure, 30 years ago was a real killer of young children. Life years gained. This is probably the most striking example of the benefits of transplantation. Really, truly, it does benefit people when they get transplanted. And the 5-year patient survival, according to recent Canadian data, with patients on dialysis is about 50% all comers. You have to recall that a lot of people who start dialysis are starting late in life, so that includes those sort of outliers who only last 6 months to a year on dialysis. But 50% 5-year survival on dialysis is pretty poor, whereas the graft survival in transplantation after 5 years is about 85% all comers. So you can just see the number of life years gained is absolutely substantial and impressive. So graft survival, the short-term outcomes have definitely improved over time, but our long-term outcomes really haven't improved all that much. And that's really what a lot of research is focused on right now. Specifically, a lot of research is focused on antibody-mediated rejection because that's felt to be a driver of long-term chronic active rejection and kidney failure down the road. So that's a big area of research, especially here in Canada. And we have some world leaders here at UBC who are heading that charge. But we do want to try and figure out ways to improve these curves even more over time. So we're doing a little bit better, but we still have room to go. So summary, transplant offers better quality and quantity of life versus dialysis. Transplant is the most cost-effective renal replacement therapy, and clearly preserving the health and length of a renal allograft is paramount for patient and society. So the objectives of this talk: brief overview of cell-free nucleic acids. I was initially going to go into the history of cell-free nucleic acids, and then I got overwhelmed pretty fast, to be honest with you. So it'll be very brief. Describe current best practice follow-up of renal transplant recipients. Introduce current and potential biomarkers to monitor allograft health. I always think you need to know where we are right now to where we want to go. And then review current research objectives within our local transplant community, just to let you know what's going on out there. So, brief overview of cell-free nucleic acids. So, cell-free DNA was first detected in 1948 by Mendel and his colleagues, but people didn't really know what they were seeing at the time. And this makes a lot of sense because Watson and Crick didn't really describe the double-stranded DNA until 1953. So we can't blame them too hard for not understanding what they were seeing at that time. The clinical importance was really recognized when cell-free DNA was compared between healthy people and diseased people. Specifically, the initial studies were on autoimmune diseases and leukemia. Many of the studies demonstrated that cancer patients generally have high levels of cell-free DNA compared to healthy subjects. And further, cancer studies revealed different oncogenes, tumor suppressor genes, that cell-free DNA may overexpress to be able to localize and determine cancer burden. So currently, there's many different fields in medicine that are attempting to adopt this very technology. Fetal medicine has been a big adopter, and this has revolutionized how they're able to diagnose genetic defects in babies. Transplantation is trying to move into this field, and really this slide says circulating DNA, but it's also the same as cell-free DNA. All of that can be sort of one term in my mind. There is sort of a couple applications in transplantation with the cell-free DNA. The other sort of nucleic acid, like microRNA, circular RNA, none of those have been extensively researched in transplantation to date. And there's a lot of room for potential development in those areas. So this is a bit of a convoluted picture here, but I think the keys I wanted to highlight here are the release mechanisms. You know, I think in the cancer world, it's cell death and clearance, so apoptosis, necrosis. Those are big factors for releasing the DNA into the circulation. And it's good to know that in those scenarios, the half-life is actually quite short. Average half-life, they say, is around 30 minutes, just because of this ongoing enzymatic activity. But there's also active release mechanisms, and these could be potentially more stable within the blood and may need different assays to fully detect. So it's important to sort of appreciate where these are coming from to know where we need to go with them. So cell-free DNA, there's sort of three main types: genomic DNA, mitochondrial DNA, and microbial DNA, with the mitochondrial and genomic being the heavy drivers. And, you know, in the kidney transplant, when we talk about it, we talk about donor-derived cell-free DNA. So really and truly, what we're looking at kidney transplant is we're looking at self versus non-self. And that's what the assays and the tests are attempting to do. Most of the assays are serum blood tests that we have, and they attempt to quantify how much of non-self is circulating in the bloodstream, and there's some arbitrary number based on data to suggest when that could signal distress within the kidney. MicroRNAs and RNAs need to be mentioned. I won't go into great detail with them because these are vast topics, each on their own. Of particular interest for me in transplantation are the small non-coding RNAs and the long non-coding RNAs. And one of the reasons is because the great stability in these molecules. I think there's potential for them to be more specific for certain transplantation endpoints. And I think as technology catches up, as the cost of doing these studies becomes cheaper, I think we might see a lot more strides in that particular field. So I think that's an exciting area over the next 10, 20 years where we in transplant need to do a lot more work in there. Applications. This is a cancer slide, but it sort of shows you the different areas that these can be used in clinical practice. As a biomarker, we can screen, detect, diagnose. We can see if they're prognostic biomarkers. There's lots of studies now looking at localization of cancers, monitoring of therapy after. All of this is important. Drug resistance, moving towards precision medicine. All of this is something in transplantation that we also want to mimic. So current best practice follow-up of renal transplant patients. Key points. There's no true standardized follow-up, despite many years of trying to come up with the optimal plan. Most transplant programs are consistent with the follow-up and the tests that they institute, but everybody basically has intensive lab visits and everyone's being monitored extremely closely from an immunosuppression, laboratory, and internal medicine type of exam. And of course, whenever we see a patient in clinic, we're always thinking we need to avoid certain complications, and especially rejection, which comes in two main forms: acute cellular rejection or antibody-mediated rejection. And remember, rejection is a complex histopathological sequence of events leading to antigen recognition, clonal expansion, so we're talking immunology here, subsequent inflammation in the kidney allograft, remodeling, repair, fibrosis, and over time, if this is left unchecked, ultimately kidney failure. So it's definitely something we want to try and avoid. And we want to recognize early before the damage is done. So creatinine is probably our global marker of kidney distress. But the problem with creatinine, as you can see in this graph down below, is that it fluctuates at the best of times. In post-transplant patients, there are many different factors that may influence the level of creatinine, so it's certainly not sensitive for true kidney distress, because volume status may alter things, infectious disease may alter things, rejection, pregnancy alters things. So it's the best we have right now, and it's the one thing that gets monitored all the time because we're very comfortable using it. But certainly it's not a gold standard per se for detecting true rejection. Biopsy is our gold standard for rejection nowadays, but the concern with biopsy is that it's invasive, it's uncomfortable. In the pediatric population, they often need to go under general anesthetic to get the biopsy or conscious sedation, and that also can have effects on people. So biopsy is good because more often than not, you can get a pathologic tissue diagnosis, which can guide treatment, and treatments can be vastly different depending on the etiology of the distress of the kidney. It is interesting to know that there are many studies talking about the inter-rater variability among pathologists. One pathologist will see rejection and another will see chronic pyelonephritis or something of that nature. So studies sort of suggest there's up to 25% discordance between pathology slides, which shows that even though this was the best thing we got, it's still not fully accurate for diagnosing true rejection that requires treatment. And certainly it doesn't push us towards precision medicine like we want to in the future. Donor-specific antibody tests are definitely tests that are serially done in transplant programs nowadays. The reason we serially monitor these are because, like I said before, chronic active antibody-mediated rejection is the dominant cause of late graft failure. Donor-specific antibodies are not specific for active rejection, however, because they don't always necessarily attack the kidney because of many factors. They may not have the right binding region on their antibody, or they may just not have detected the kidney, because sometimes the kidney can sit in a place of immune privilege or immune tolerance, like we like to say. Certainly, if you do have new donor-specific antibodies without rejection, that can be a sign that you need more immunosuppression to sort of prevent those from developing and prevent those from causing damage down the road. But really and truly, we want to know about donor-specific antibodies, because once you have those, usually immunosuppression gets ramped up to try and prevent rejection and increase the life of that kidney. The only other thing I'll mention on this slide is that antibody-mediated rejection is particularly a destructive process with complement activation and subsequent cell lysis apoptosis. That's very important for the cell-free DNA technology that we have in transplantation right now. So we'll come back to that. Other tests, transplant ultrasound, certainly non-specific, but give us anatomic details and can hint at medical renal disease, specifically with increased resistive indices and loss of corticomedullary differentiation. Urine albumin creatinine ratio, once protein starts spilling in the urine, that's thought to represent glomerular damage, and that can often trigger biopsies to see what the exact cause of that is. It could be recurrent kidney disease, it could be rejection, it could be infection, it could be many things. It could be just chronic failing kidney. So here's where we're at right now. We have sort of the non-invasive and the invasive tests. We have less accurate and more accurate. And the creatinine, the protein in the urine, the donor-specific antibodies are less accurate of rejection. And the biopsy is the most accurate thing we have right now. But we certainly would love to fill something in that box in the top right corner, something non-invasive and more accurate for diagnosis. And that's where genomics and cell-free DNA come in. So these are some shortcomings that you can just sort of briefly glance over. But I mean, in kidney transplantation, there's a crucial need for minimally invasive biomarkers that are more sensitive and specific than plasma creatinine and even kidney biopsy to allow early actionable detection or exclusion of structurally related renal damage. So that's where we're sort of heading towards in this field. Current and potential biomarkers to monitor allograft health with emphasis on donor-derived cell-free DNA. So I wanted to put in a little translation and industry and sort of see why this matters. This is CareDx. CareDx is the maker of a test called AlloSure. And AlloSure is a cell-free DNA-based test that is FDA approved right around here. Right around here, it was FDA approved for monitoring kidney allograft health post-transplantation. And as you can see, the stock price of this has just sort of skyrocketed. I think COVID came in here and dropped it down a little bit, but it's back to all-time highs. And this particular company is very aggressive in their marketing, and they've really pushed their product out there. And I think they're probably the big dogs in town when it comes to utilizing sort of next generation sequencing and this type of technology in a translational aspect. And it's sort of interesting as I go through it. I don't want to present any biases, but I'll just tell you my bias. We often will make a little bit of fun of AlloSure, saying the test is I'm not sure, because it's supposed to hint at if there's rejection or not. And unfortunately, the sensitivity and specificity of the test are not all that great. And I'll go over some of the data on that for you. But so it's interesting that sort of an imperfect test has made such a move in the business world. And I think that just highlights on what a need there is for this type of biomarker in the realm of transplantation. So just like in the cancer slide I showed you earlier, the clinical applications of donor-derived cell-free DNA, right now, they're diagnosis of rejection, surveillance of graft health. There are many transplant centers who use this donor-derived cell-free DNA test at serial visits. And if it starts becoming elevated, the test, then that'll trigger a biopsy for a confirmatory diagnosis. So it is being used as a screening test in that regard. It can also monitor therapeutic response. The half-life of cell-free DNA is so short that within days it will come down if kidney damage is ceasing. So the technologies currently used in clinical donor-derived cell-free DNA assays, well, there are two real approaches. There's this random or shotgun approach, or targeted differentiation of donor and recipient cell-free DNA. The random approaches use adapter ligation and subsequent next-generation sequencing. The fragments carry SNP markers, and these are sequenced as they appear in the plasma. And with these random technologies, both of them require some form of genotyping to determine self from non-self. Different sets of pre-selected SNPs are used in droplet digital PCR, which is more common in the targeted technologies. And I'm going to focus now on AlloSure, because that's the one that when I was at Wake Forest, we actually did protocol serial AlloSures, and that's the one I have the most experience with. And I think it's interesting. It's interesting to look at how that particular technology works and what the data is surrounding it. So this is specific for AlloSure with the targeted technology. So basically, again, it's next generation sequencing of a targeted panel of SNPs. So what they have to do is they extract the cell-free DNA, and these are in special tubes from patient plasma. They amplify the SNPs using loci of multiplexed PCR. You can see the word amplicon there. An amplicon is a piece of DNA or RNA that is the product of amplification or replication events. So basically, they have to sequence all of these amplicons. And then after they're done that, they have to calculate the fraction of donor-specific nucleotides. And that's how you get your number, or your percent of donor-derived cell-free DNA within the body. And the percent that most companies use for showing some sort of pathologic abnormality is greater than 1% donor-derived cell-free DNA within circulating plasma. So the nice thing about this method is it does not require genotyping. The example is, 99 counts of allele A are found and 1 count of allele B. They infer that the recipient is made up of allele A, whereas allele B is the non-self, or the donor-derived cell-free DNA, and that's how they come up with their estimation. So it's interesting technology that they're using, and it has found a place in clinical practice. So the key results, an overview of donor-derived cell-free DNA research before we dig into some of it, is donor-derived cell-free DNA is very low in stable transplant patients. So that means the cells aren't constantly undergoing apoptosis or necrosis, and there's not active transport out of these donor kidneys. Donor-derived cell-free DNA is elevated at the time of rejection. That's clear. But you can see the fourth point, it's also elevated during many other things. And that's one of the problems with donor-derived cell-free DNA, is it's not specific for rejection. But it is true that you can monitor successive treatment with this type of technology as well. So we already know it's an established biomarker in prenatal testing and oncology. And again, AlloSure is the first clinically validated donor-derived cell-free DNA test for kidney transplant recipients. And that's why you can see its stock price has skyrocketed over the last couple of years. So the relationship of donor-derived cell-free DNA to allograft injury, well, it's pretty simple. The DNA is released, we measure the DNA, and a high level indicates potential organ injury. So the DART study is basically what AlloSure's data was validated on. And we'll go into the DART study, which itself is not a perfect study, but it was good enough for FDA approval of this biomarker, and we'll show you about it. And a lot of these slides were provided to me by Dr. Jonathan Bromberg, who's this guy right here. He's a professor of transplantation surgery and immunology at University of Maryland. And he's also on the board of AlloSure as well. So he does have a conflict of interest with AlloSure. He speaks on their behalf at many different places around the world. But a great guy and very generous with talking to me about this particular subject. So I'm going to try and present it in as non-biased a way as I can. But it is exciting. I got to say, it is exciting because it's something different than we've had before. Even though it's not perfect, it's trying to push the needle in the right direction. So the DART study design, there were 14 centers, 384 patients. This was a prospective observational study. It enrolled patients within 1 to 3 months of transplant and followed them longitudinally for 2 years. So I'll show you on the next slide. Basically, there's two groups. There's one that was sort of surveillance monitoring following transplant, and there's one that were enrolled at the time of suspicion of rejection. So the likelihood that this group here will have rejection compared to this group is much, much greater. And I will say that the data out of the DART study was based all on this group. This group had very low event. They actually had only one rejection episode in all of this group, so they couldn't draw any conclusions from surveillance. So that's an important point as you're thinking about this. And I won't go into the specific criteria for what rejection is today. So these are the two clinical scenarios as I hinted at. So these are the surveillance people, and they had 11 total AlloSure tests. And if the AlloSure test was elevated above 1%, that would trigger a biopsy. Clinically indicated biopsies, here they had the for-cause biopsy and a donor-derived cell-free DNA at the same time, and then they followed 8 weeks and 8 weeks later, and that was their second sort of arm of this particular study. So the aims of this study were to determine the ability of donor-derived cell-free DNA to discriminate active rejection from no active rejection. The secondary aims were to determine the ability of donor-derived cell-free DNA to discriminate antibody-mediated rejection from the absence of antibody-mediated rejection, and they wanted to compare the performance of donor-derived cell-free DNA to serum creatinine. This particular study, it does meet both secondary endpoints. The primary endpoint, I don't think it probably met the primary endpoint, and we'll go through that. So this sort of is just a flow chart of how they got to their analysis cohort. But basically, down at the bottom here, there were 27 patients with active rejection, and this was the cohort that was more likely to have rejection on the basis of clinical parameters that we've already established earlier. And of these, 11 of them had T-cell mediated rejection or acute cellular rejection, with the other ones having antibody mediated rejection. 75 of these patients, comprising 80 biopsies, had no active rejection. So this is the group that they ended up comparing. And it's interesting too, some of their exclusion criteria for patients, up to 50 patients had no blood samples with the biopsy, so they couldn't perform AlloSures on these particular patients. So there was a lot of missing data in this particular study, which, when we're talking about these low numbers that they have, that could have drastically changed the results. So this is part of their secondary aims. This basically assessed active rejection versus creatinine, and you can clearly see that creatinine really doesn't push the needle between rejection and no active rejection between their two groups, but certainly AlloSure it does push the needle. If you're looking at no rejection versus rejection in a population that you're suspecting might have rejection, then AlloSure does perform quite well in that scenario. But interestingly enough, even in the no active rejection area, there are still AlloSures that are above the 1% threshold. So this is probably the largest and most high impact finding of the DART trial, and this is that AlloSure does have pretty decent ability to detect antibody-mediated rejection. And the reason for that is like I said earlier, antibody-mediated rejection is an extremely destructive process, and there is tons of damage to the kidney that results from the attack of antibody in the immune system on the kidney. So AlloSure tests will be very high in this scenario, even going up to almost 8% donor-derived cell-free DNA within the bloodstream, which is a tremendous amount. So this is quite a profound result, I think, and it's something that the makers of CareDx certainly sell when they're trying to push AlloSure on you. Interestingly enough, acute cellular mediated rejection did not perform nearly so well. There's many acute cellular mediated rejection episodes that are under the 1% allograft threshold, and this is just not as damaging of a process acutely, but over time, this is also a killer of the kidney. So that's something that should be recognized. So this is the results from DART. The sensitivity was 59%. The specificity was 85%, they say, for active rejection, although I think future studies have sort of, some have confirmed and some have downplayed that for rejection. The biggest thing that came out of DART and what they sell people on is the negative predictive value. A negative test, they say, basically rules out rejection. I think it's true that it almost rules out antibody-mediated rejection, but cellular-mediated rejection is still possible, even with a low AlloSure. So the key points from DART. I think the primary endpoint was not totally proven. I don't think AlloSure can completely determine rejection from no rejection. I think it definitely can. It can signal kidney injury versus no kidney injury in a general sense. I think it is more accurate than serum creatinine in the diagnosis of rejection because creatinine is a late riser, as we know. I think it is more sensitive and specific for antibody-mediated rejection than anything we have right now. I think the levels do decrease following rejection treatment. And I think that is a realm where I think it is finding a home to see response to treatment. I think these many centers that have adopted AlloSure as a surveillance tool to trigger biopsies, I don't think DART proves that is a good use of this. I think the best use of an AlloSure test is on a case-by-case basis, and only when the suspicion of rejection is high, if you're looking to avoid a biopsy in the patient, because a negative AlloSure may let you sit on things a little bit longer. So what about other studies? Well, this study of 76 patients took two different competitors. They took AlloSure versus Prospera, and you can see, once again, the numbers aren't breathtaking. The sensitivity of AlloSure was 45%, whereas Prospera was 54%. I have no experience with Prospera, but you know, when I'm thinking about a biomarker, I want something sensitive that rules in the disease, that tells me it rules out any disease. And this is just very non-sensitive, unfortunately. Some other studies that have been done. These studies actually show more promising results. You can see that its negative predictive value is what cell-free DNA hangs their hat on in transplantation. But again, the sensitivity is very variable, and I didn't include some other studies, but there's many studies that have sort of the sensitivity and the specificity in sort of the 40 to 60 range, and the specificity in sort of the 60 to 80 range. So certainly not perfect tests to date, but it has pushed another tool into our pocket. So we do have something now occupying that right box. In Canada, our ability to use this right box is very limited, and the reason that it's very limited is because of the cost. The cost of AlloSure, and probably one reason why that stock went up so high, is it costs up to $5,000 per test. And in the US, insurance companies are paying this all the time. So that's why it's not out of pocket payment for patients. CareDx has really sort of worked their way into, in some ways, convincing people that they're an essential part of kidney transplant monitoring. So the question is it worth the cost? And I would say it is not worth the cost in Canada right now. I think we do a pretty good job at monitoring patients because we follow them so closely. And I think it is nice in cases that are questionable what's going on. But again, it's so nonspecific that that biopsy will often be performed for mildly elevated AlloSure, and patients just hate getting biopsies. I put this graph on here again because if you measure an AlloSure over time, very rarely is AlloSure completely straight over time. It also fluctuates over time a little bit as patients go through different events in their life, and interpreting AlloSure can be a little bit challenging sometimes. So I don't think it's made it to prime time yet in Canada, and I think that's why we have a lot of potential to develop new technologies that can build on what's already been built here. There are other studies looking at different sorts of markers. Certainly, donor-derived cell-free DNA is the big kid on the block right now, but there's also blood gene expression profiles being touted, and this true graft is one that I think the University of San Diego is pushing quite heavily, but it hasn't gained much traction in the transplant community as a whole. Urinary mRNA is also possible. Urinary levels of chemokines are very interesting, and we have Dr. Tom Blythe-Hansen has done a lot of work on CXCL10, and he's proven it to be a potential marker for kidney allograft injury and rejection. There's also proteomic studies, and there's people trying to push the needle, but a lot of these haven't made it into clinical practice yet, unfortunately. Where the field is going is combination of tests. We're taking sort of this is the next wave over the next year or two, where we take tests that are sort of average and we put them together and we see if we can make a better test. So I always think it's funny when we do that in life, but I think it's got a purpose, and if we can see that we can have a conglomeration of tests that show an endpoint, then that would be extremely exciting. So quick review of current research, and then I'll end and I'll open it up for questions. So I talked about Dr. Tom Blythe-Hansen at BC Children's Hospital. He does some amazing work on metabolomics and urinary chemokine profiling. And I'm excited to see what he has in the future. He's also established a pediatric biobank of urine, blood, and tissue specimens, which is an incredible resource. And we look forward to seeing what's going to come out of there more. And I look forward to hopefully collaborating with him in the future at some point in time as well. St. Paul's does a lot of epidemiological clinical trials and access to care. VGH, which I'm most familiar with, under the direction of Dr. Paul Keon, and also with James Land and Karen Sherwood, they're part of and helped establish the Genome Canada Transplant Consortium. And the whole idea of this is minimizing antibody-mediated rejection in renal transplant patients. And this also comes with an established biobank with blood and urine. The tissue specimens are stored at St. Paul's Hospital under the direction of the renal genitourinary pathologists. And any research initiatives that happen sort of go through them if you want to use tissue, which is great to have sort of this multidisciplinary team and collaborators. So the Genome Canada Transplant Consortium, I mean, I think it's interesting. They're very well organized, they're well funded, and they really have good goals. The first goal is epitope matching. Current methods to match donor kidneys with recipients are imperfect, and they're hoping that this epitope matching might push that into better matching profiles, which in turn will lead to longer lasting kidneys and potentially less immunosuppression for patients and potentially less complications. Immune monitoring is a big thing that they're doing, and this is all about what I'm talking about today with nucleic acid discovery, and they're going to be doing some good work in this field, and then they also go into more policy, social things, and I think this is a big sort of funding principle that I'm understanding nowadays is you don't just want to be so focused in one lane. Funding agencies like to know that you're thinking about psychosocial, gender, equity with all people, and I think that that they're doing a nice job with this in their Genome Canada Consortium. They're also developing new laboratory technologies, which I think is also very exciting, and some of these are already making their way into clinical practice in immunology laboratories, and it's neat to know that here at UBC they're on the forefront of this type of technology. So at the end of the day, the future of transplantation, probably the future of any field in medicine, is going to be data integration. It's going to be figuring out new tests. And it may not just be one single test that pushes the needle. It's probably going to be a panel of tests. It is extremely exciting times right now. I think the field of genomics and transplantation, although there is a lot of publications, I still think there's a ton of work to be done, and I think I'm really excited to be joining this sort of revolution at this stage in my career, and I hope to be able to contribute something to science and to help these patients down the road. So my interests are circular RNA and transplant. That's what I got the CUA grant for. Microbiome evaluation of transplant recipients with Dr. Dirk Lang, and many other collaborators on that particular topic, too many to list. And then KEG and DO and Raman spectroscopy, and the circular RNA is help with Dong in the lab. So essentially, all the studies that I'm looking at, I'm right here. So I realize when I look at this type of a graph, there is a lot of work to be done, and I know that in order to get this going, I can't do it on my own. I already know that I need a lot of help, and having good ties and meeting up with people and picking their brain and their expertise is a key to being able to do any quality research nowadays, because things are too complex to go it alone, I think. So, in conclusion, we have an active transplant research community in British Columbia, and it's exciting to be a part of that. My opinion of donor-derived cell-free DNA is it's another clinical tool. It's not specific for rejection, but probably better than creatinine. I think combining markers is what's the immediate future, and the long-term future is developing new markers. I think non-coding RNA analysis really has a lot to offer our field, and I'm hopeful that we can get some more specific tests out of it and more sensitive tests. And I think there is room for surgeons to become involved in this type of research. It is a huge deal in the United States. In the U.S., many transplantations are run by surgeon scientists. And Canada, our model is quite different. Nephrology is extremely strong, and the work that they do here is incredible. And I think we have more nephrology-run transplant programs in Canada. And I think there's room for all of us to step up and to participate in this exciting field.